So welcome everyone to this deep dive meeting on we're going to be looking at invasive fungal infections in the stem cell transplant setting, but I think we could just as well talk about hematology, but because there is a lot of overlap, particularly in the myeloid setting between the two. So we're going to kick off with two speakers and then a panel discussion following that. So housekeeping, you can see all of that just in terms of we do encourage interaction, so add your questions to the chat box, or we may, if we still have time at the end, you can certainly chat online. And the CPD, you do need to be for an hour to get that, and obviously feedback is welcome. And then just to say, the registry conference, not necessarily the cheapest registration, but certainly discounted registration is for people who are members of these groupings, and it is in Cape Town, so we get there. And then obviously HEMONC later in the year. Unfortunately, I won't be there, but we hope the rest of you will also in Cape Town. So yeah. In terms of, let's move to the next slide and then deep dive. So just, yeah, well, I think, again, thank you to all these people. So Bridget's going to kick off. So she's a physician and trained at Wits, who's now at UCT, working at Blood Assay and also in conjunction with the Department of Hematology at Groote Schuur. And then we followed by Tari, who's an infectious disease specialist at Groote Schuur Hospital, as he's also made the trek south from Gauteng. So you can see his bio over there. I'm not going to go any further on that. And then going to be quite challenging to manage a panel discussion, but two infectious disease / microbiologists and two hematologists, both of whom are transplanters at Groote Schuur Hospital. So full program to get through. Bridget, let's kick off.
Thanks, Andrew. I'm going to share my screen now. Good afternoon, everybody. My name is Bridget. We're going to run through a couple of case presentations of patients with invasive fungal infections in the last couple of months at Groote Schuur Hospital. Our first case is Miss AA, a 29-year-old female with a background, no known comorbidities, HIV negative, with relapsed refractory classical Hodgkin lymphoma, diagnosed in 2022 on biopsy of a cervical node. She was 18 months pregnant at the time. There was also a concern for alpha thalassemia trait, but her hemoglobin electrophoresis was negative. In terms of her chemotherapy history, it was quite extensive. She was initiated on ABVD, had an emergency Caesar just before her 4th cycle, and following cycle 4A, she still had nodal disease of Doble 5 on a PET CT scan. Classical Hodgkin's was confirmed on a lymph node biopsy at this point, and the decision was for salvage chemotherapy, the patient to stop smoking, and then an autologous stem cell transplant. Following 2 cycles of Bejev, she had progressive disease. She was then escalated to BV plus ICE, still progressive disease on another PET CT. She then had 2 cycles of DHAP, still with progressive disease, had radiation to the involved site, and following this on PET CT was then found to be in complete molecular remission. She was then admitted for a hematopoietic stem cell transplant, and the day before her transplant was found to be COVID negative and started having diarrhea, which was thought to be associated with the COVID at the time. She had an uncomplicated autologous transplant, and then on day 4 started spiking temperatures and was initiated on meropenem empirically. Her stool cultures were all negative, and her diarrhea was subsequently improving on loperamide. she had multiple blood cultures done around this time. And on day 7, we got the results from blood cultures done 2 days prior from her Hickman line to say that she'd grown a Candida dubliniensis. At the time, she also had a persistent tachycardia and was quite concerning because of the severity of the tachy. She was even given adenosine, and it was subsequently decided that this was likely due to her sepsis and anemia. The following day, her Hickman line was replaced and she was switched to micafungin. Clinically, she still was quite unwell with tachycardia, ongoing temperature spikes, some upper respiratory symptoms, and the diarrhea. She had previously been escalated to antibiotics at this point, and they were subsequently held, and all of the septic workup at that time done was negative. By day 19, post-stem cell transplant, she'd received 12 days of micafungin and was clinically well at this point and was subsequently discharged on fluconazole. Here you can see her blood culture. The gram stain showed yeast cells, which was shown to be a Candida dubliniensis. And you can see there that it took 32 hours for this organism to be confirmed. Here's a summary of her FBCs in relation to her transplant and antibiotics, just to highlight how neutropenic she was. Her transplant, obviously there at day 0, the 3 days of marrow, where the Candida was cultured, and then obviously 2 days later, once it was known, she was started on the ampho and then the micafungin with the PIP and AMIC, which was subsequently stopped. Then moving on to our second case, we have a Miss WP, a 49-year-old female, a teacher from Crawford. Again, on background history, HIV negative, known with a multifibroid uterus and iron deficiency anemia, as well as a severe aplastic anemia with a PNH clone. She was admitted on the 21st of February from home with fevers and fatigue and some vomiting. Clinically, she was relatively stable with minimal bruising on her legs, but not much else to find, and was diagnosed with a neutropenic fever. And at that point, initiated on cefepime and amikacin. The concern was that she had a possible penicillin allergy, and a septic workup was done. This is an image of her chest X-ray on admission. During her course in hospital, she received 3 days of amic and cefepime, as mentioned, and subsequently was escalated to meropenem because of ongoing temperature spikes. Septic workup done on admission was unremarkable. Her chest X-ray remained unchanged, and her IV lines were changed. She was cleared for the penicillin allergy by testing done by immunology. And on day -7 pre-transplant, had a Hickman line inserted. She had conditioning with fludarabine and busulfan. And then subsequently on day -3, she had some pain over the insertion site. That Hickman site was noted to be tender and red, and she started spiking temperatures. The line was then removed. She was initiated on pip-taz, amic, and Clinder to cover her for neutropenic fever, and a new Hickman line was inserted under platelet cover. Again, here is a summary of her results in relation to her antibiotics and the transplant being the day right at the end there on the right. And again, just highlighting the extent of her neutropenia at the time. Then on day 0, she had an uncomplicated haplo stem cell transplant. However, the following day started spiking temperatures and had rigors, and there was still concern about this Hickman site. She had an ultrasound which showed no drainable collections and no thrombi, and was escalated to meropenem and Vanco at this time. Following 2 doses of Vanco, she started developing renal failure, and this was subsequently held. On day 4, she was still having fever and rigors, but then started desaturating and her level of consciousness dropped. Ongoing renal dysfunction, but her renal ultrasound was unremarkable. And the concern at this point, differential included cytokine release syndrome, which would have been expected, as well as possible fungal infection or TB. The other worry was the possible Hickman site infection. She had also developed a skin rash. Dermatology had been consulted, and they felt it was most likely acute graft versus host disease. And at the time, she still had severe cytopenias. She had an extensive workup done, which was all unremarkable: blood, urine, stool, respiratory panels, all negative. And she went for a high-res CT chest. And here you can see some images of the CT. The report showed hematogenous spread of infection, possibly viral, atypical bacteria, or fungal, including aspergillosis. And this at the time was considered to be the most likely diagnosis. So she was initiated on voriconazole at day 7 post-transplant. Her voriconazole levels remained therapeutic. She had a galactomannan level done, which was negative, and unfortunately we were not able to send her for bronchoalveolar lavage, as she was too unwell at the time and was felt that she wouldn't tolerate it. Here are some images of her temperature charts with the antibiotics that were given at the time when the Hickman was inserted and removed. Their stem cell transplant in the red, escalation to Mira and Vanco, and then the voriconazole. And here again, just the relationship between her white cell count, absolute neutrophil count there right down at the bottom, the day of transplant at the top, and the various antibiotics and antifungal cover that she received. So I've got a couple images of her chest x-ray throughout her admission. So remember the x-ray from the end of Feb. This was the 9th of March. This is what it looked like on the 17th of March, and then the 30th of March. So she is currently now day 38 post-transplant. She's clinically remarkably improved. She's defervesced, as you can see from her temp chart. She's comfortable on room air. Her renal function has recovered. She does have a critical illness or steroid-induced myopathy, but she's mobilizing and receiving physiotherapy. And she does also have skin and GIT graft versus host and is on a steroid taper. And the last case, very briefly, and just because it's quite an interesting presentation of the same disease, we've got Mr. SM, a 25-year-old gentleman, again, HIV negative with a severe aplastic anemia, was admitted on the 12th of December last year for a matched unrelated donor stem cell transplant, and was found to be CMV positive, received ganciclovir and Valgan throughout his course. Had an uncomplicated stem cell transplant with the conditioning and immunosuppression you can see there. On day 6 post-transplant, was noted to have a painful bleeding ear, was seen by ENT and started on ear drops. 2 days later, he was having ongoing temperature spikes and ear pain, and there was a concern for mastoiditis or a collection. And a few days after that, he developed a lower motor neuron, 7th nerve palsy, and was noted obviously to have a complicated otitis. However, he had subsequently a CT head which showed otomastoiditis with no collections, and a bone biopsy was done. And he also had a positive BDG at this point. And the bone biopsy showed fungal elements compatible with Aspergillus, fungal yeasts and pseudohyphae, as well as Candida. And he too was treated with voriconazole. He had quite a complicated admission, but was ultimately discharged on day 23 of treatment. At the time, his wound had healed and he was clinically well. So at this point, I'm going to hand over to Terry to give us his talk.
Thanks, Bridget, and thank you, Andrew, for your introductions. I'm just going to share my screen. Okay, just checking everyone can see my slides and can hear me nicely.
Yes, thanks, Terry.
Okay, brilliant. Thank you for this opportunity to give this talk on invasive fungal infections in stem cell transplant setting. So just to tell you, I'm actually at UCT, and I'm quite pleased to see that Sean Wasserman, who was one of my teachers, is also on the call and has a lot of experience in hematopoietic stem cell transplants. So let's get going. Okay, so I'm going to be discussing basically two things over here. I'm going to be talking about the patient that had the candidemia, and I'm also going to be chatting about the patient that had the aspergillosis. Not really going to go into prophylaxis, as I think that needs to have a discussion on itself, because it's quite a big topic. So let's go into the candidemias. And I had a couple of questions that went through my mind and thought we could discuss the way forward with regards to how to approach candidemias. Now, what is the epidemiology of candidemia? What are the risk factors? What is the utility of beta-D-glucan? Does the time to positivity make any difference to the outcome of patients? And as Bridget had mentioned, that the first patient was positive, her blood culture came back positive within 32 hours. And then what are the empiric options for Candida treatment? And I've tried to keep that simple based on what we have available at Groote Schuur Hospital. And I'm also going to discuss a little bit about treatment duration and some new literature that's coming out with regards to that. Okay, so this was a prospective surveillance of invasive fungal infections. It was done in 875 patients in the United States out of 23 transplant centers. And basically what they showed is the organisms that are most commonly involved with invasive fungal infections is Aspergillus, seen in 43% of cases, invasive candidiasis in 28, mucormycosis in 8, and other was around 21%. And the other included patients with cryptococcus, PCP, and fusariosis. Now, of that 28%, what were the organisms that were seen from a Candida point of view? And as you can see, Candida glabrata was the most common. Its name is now changed to Nacosomyces glabrata, and that's what's seen in 33% of cases. The next most common is Candida albicans at 20%, Candida parapsilosis at 14%, and then Candida krusei, which has now changed its name to Pichiae kudrivasevii. Apologies, I've probably hashed how to pronounce it. It's quite a difficult name, as you can see. And then Candida tropicalis is Candida, and Candida lusitania, much less common overall. Now, thank you to my colleagues at Groote Schuur at the National Health Laboratory Services, who gave us this data pertaining to the organisms that we are seeing in our hospital. This was over 5 years, 6 years, between 2018 and 2023. It was 33 patients. And as you can see, there's quite a multitude of organisms that we are seeing. And importantly, to keep in mind of this, it includes hematology, oncology, and hematopoietic stem cell transplant patients. So it's over 4 units. It is not only candidemias, it also includes aspirates, etc. So it's not purely candidemias. Now, as you can see, Candida albicans is the most common, then Candida glabrata, and then this very unusual organism over here called Candida pelliculosa, which was identified sometime last year after there was an outbreak of this organism, which we thought might have been related to a infected KY jelly, not going to mention which the company was. And this KY jelly was actually found in many other parts of South Africa, and there was a whole expose about this organism and its contamination. And it was thought that it was related to people inserting central lines and under ultrasound guidance, as well as people inserting urinary catheters with this KY jelly. And then, as you can see over here, the Candida dubelinensis, which Bridget mentioned about the patient that the first patient, and as you can see, it's actually not a very common organism in our area. But in saying that, as you can see, we've only got 33 patients with us. To go on to the next slide, what I find quite interesting is why aren't we seeing much Candida auris in our hematopoietic stem cell transplant patients? Because if you look at some previous data from around 2016, 2019, Candida auris was the third most common Candida species in public and private hospitals. In saying that, we haven't seen any Candida auris species at Groote Schuur Hospital that have been from Groote Schuur themselves, but we have seen Candida auris being brought in from other hospitals to our units. And what's interesting about Candida auris is that it's not actually a gut commensal and doesn't grow very well in anaerobic environments, which is what we expect in the GIT. And also, the other interesting thing about Candida auris is that it evades neutrophils, and therefore there's no neutrophil extracellular traps are produced. And that essentially means that neutropenia is not a risk factor per se for Candida auris. And that's also another reason why we're not seeing this much in our units. Now, what are the risk factors? We've heard about these patients that have received multiple courses of chemotherapy, and also the neutropenia that they have. So if you look at the immunocompromised section, we know that granulocytopenia is a problem, stem cell transplants, mucositis, graft versus host disease, the type of chemotherapy, especially cytotoxic chemotherapy, as well as organ transplants, liver, kidney, heart, etc., etc. And then from a non-immunocompromised state, we can see broad spectrum antibiotics are there. And many of our patients in our hematology units do get broad spectrum antibiotics. And that's based on these patients being quite ill. And then again, renal dialysis, central venous catheters. A lot of our patients get Hickman lines. A lot of the patients are sick. TPN, total parenteral nutrition, not really used much. And then we don't see a lot of GIT perforation or surgery in our hematopoietic stem cell transplants. In saying that, we obviously see that quite often in our surgical units, and that's part of the Candida score, which also incorporates Candida colonization. And then there are other parameters. I'm not going to go into the neonates. I'm an adult ID physician, so we'll leave that out. And then there was this rather interesting study looking at diagnostics and the utility of using beta-3 beta-D-glucan with regards to antifungal therapy in patients in an ICU setting. So it was called the Candicept trial, and it was done in Germany in 8 ICUs. And basically, they had 2 groups. So the one group was antifungal therapy started on the basis of 2 beta-D-glucans of more than 80 on a day apart. And then compared to the control group, which was antifungal therapies based on the standard of care. So, for example, if a patient develops a candidemia, then they would start. And this is basically what they showed, is that in the beta-D-glucan group, The 28-day all-cause mortality was sitting at 33% compared to the control group of 30.5, and the p-value is not significant. But the antifungal free survival at day 28 showed that obviously in the control group, there was far fewer patients started on antifungal therapy. And the time to antifungal therapy, obviously in the beta-D-glucan group, was higher, was started earlier, apologies, at 1.1 days versus 4.4 days in the control group. And essentially what the authors were saying is that the utility of using beta-D-glucan in this group doesn't change your mortality outcomes in these patients. But please keep in mind, this is not patients with hematopoietic stem cell transplants. This was in an ICU setting. And this is the graph that I was talking about with regards to the mortality. And as you can see, that the mortality in the beta-D-glucan group versus control group were very similar. So no significant difference between the two groups. All right, so now going into other modalities with regards to the diagnosis of candidemia and invasive candidiasis. Looking at blood cultures, they have a sensitivity of 60 to 90%. In saying that, there's quite a lot of variables that one needs to take into account when doing blood cultures on these patients. For example, patients that are already on fluconazole prophylaxis, that sensitivity will also drop. And it also depends on how many milliliters of blood is inserted into the blood culture bottle. So in actual fact, the studies support putting in 40 mils of blood into blood culture bottles. So that means 4 blood cultures, which we don't do in our setting. It's rather expensive to do 4 blood cultures. So we generally just do at least 1, preferably 2 blood cultures on these patients to try and increase our yield, as well as to decrease the risk of finding commensals or contaminants on those blood cultures. And then to look at the beta-D-glucan, which we are going to discuss a little bit more in the next couple of slides, is looking at the performance. So the sensitivity is around 50 to 90% with the specificity of 70 to 100%. But when we get there in a few slides' time, we'll discuss what are the other factors to consider in those patients. I'm not going to go into too much detail about PCR and T2 MRI imaging because that is something that's not readily available for us and very expensive modalities as well. So something that was interesting when I was looking at this patient's results is the time to positivity was interesting in the sense of it came back positive within 32 hours. And I was thinking, is there any literature to show that there's prognostic markers of mortality with regards to the time to positivity? And the study that was done in Sydney, Australia, basically looked at 527 patients over a 2-year period between 2014 and 2015. And the time to positivity was a median of 48 hours with the interquartile of 33 to 65 hours. And what was interesting is that the 1-day reduction in your time to positivity multiplied by an odds ratio of 1.32 for the 30-day mortality. And you can see that in this graph over here, where basically it shows that if your blood culture was positive only after 5 days, your 30-day mortality was lower compared to those patients that your blood culture was positive within 2 days, and our patient was positive within these 2 days. So the patient's mortality would be significantly higher compared to the ones which is later on. And that also speaks to, is this an inoculum effect where you have a lot of Candida in the bloodstream, which causes it to be positive much sooner? But obviously in this trial, there's quite a few caveats. And One of the caveats being is, did the blood culture bottle get taken down to the lab as soon as possible after the blood was taken? Was it placed in the incubator on time, etc., etc.? Okay, so I looked at cost of drugs because in the Western Cape, there's big issues with regards to finances, and we're trying to save money where we can. And as you can see over here, that this is the treatment of the various antifungals for 14 days, and their echinocandins, which is the go-to drug, sits at 8,400 Rand for 14 days. That's IV. Amphotericin B only at 2,200 Rand in comparison. And then liposomal amphotericin is much more expensive at 25,000 Rand. Compared to fluconazole, this is not the IV formulation, but the oral formulation, which is 31 Rand. So quite a marked difference between the prices. And in Groote Schuur Hospital, we mainly have micafungin, as it is the cheaper of the echinocandins that is available to us. All right, so looking at the effectiveness of the various drugs. So this was a systematic review and meta-analysis comparing amphotericin B, the azoles, as well as their echinocandins. And as you can see over here, this was looked at 13 studies with 3,528 patients, and the primary outcome was treatment success, and echinocandins were used in 1,531 cases, patients, and then 944 with amphotericin B, and the azoles in 1,053 patients. And if you look at the forest plot over here, you can see that treatment success of azoles compared to amphotericin, or echinocandins compared to amphotericin, one can see that there is a better treatment success in the echinocandin arm compared to the azole arm. But if you look a little bit deeper into the various antifungal agents, in actual fact, as you can see from this forest plot, that all of them cross the one with quite long confidence intervals on some of the drugs over here, especially liposomal amphotericin B. But if you culminate all the data together, the echinocandins are seen as the better agent with regards to the treatment of candidemia. Now, this is quite an important slide with regards to when to de-escalate. So if you read the latest guidelines in clinical infectious diseases, they are getting a little bit old, 2016, but de-escalation of antifungals. So what I mean by that is changing a patient from an echinocandin to a azole, such as fluconazole. That should only be done after the treatment has been given for 5 to 7 days, and the patient is stable, and the susceptibility of the organ of the fungal candidemia is known, as well as repeat cultures that are negative. And those repeat cultures can be done after 24 to 48 hours after the initiation of an antifungal treatment. We don't do every 24 hours because it comes at quite a high cost. We do it every 48 hours. And once it is negative, then we start treatment as day one from the first negative blood culture. Now, in saying that, what we have been doing is we actually de-escalate a lot sooner than the 5 to 7 days of therapy, and that's based on knowing that the patient is susceptible. So our most common species, that, as I mentioned earlier, is Candida albicans. So if we know it's a Candida albicans with susceptible to fluconazole, which ours are, then we de-escalate sooner rather than later, because echinocandins are very expensive, and furthermore, it's good antifungal stewardship to try and de-escalate from an IV option to fluconazole and to an oral fluconazole option, as well as changing to a cheaper drug. And importantly, I cannot stress this enough, is that it is pertinent that we have good source control, because if you don't have good source control, more likely than not, your patient's cultures will remain positive, and we'll struggle to get on top of the infection. Okay, another important side, we get this question quite often, is what are the penetration aspects that one needs to take into account when giving the various antifungal agents? And as you can see, fluconazole has got excellent urinary presentation, and actually, in actual fact, it's 10 to 20 times higher than the serum concentration. And CSF and vitreous fluid is 70% of the serum. And we've got a lot of experience in giving fluconazole. If we think about our cryptococcal infections, it is a drug that is used all the time. And if you look at your polyenes, you can see that liposomal amphotericin has good CSF penetration, but not as good for the urine. And amphotericin B has less CSF penetration, but good urinary penetration. But we obviously use amphotericin B all the time for our cryptococcal meningitis patients, and we've got a lot of experience with those cases. Furthermore, looking at their echinocandins, it's very important to note that it has poor CSF penetration, poor eye penetration, and poor urine penetration. And we recently had a case where the patient was treated for this candidemia with an echinocandin, then rightly changed over to a fluconazole regimen, and patient was fine, was discharged, and the patient came back with this candidemia again. And when we looked a bit deeper, we actually found that this candida was most likely coming from the urinary symptom, and the patient had underlying hydronephrosis, etc. So that was probably the source of this candidemia from the urinary tract. And because echinocandins don't have very good urinary penetration, we suspect that the patient had a recurrence of this disease because of poor penetration. Okay, and now we've already discussed this patient that had this Heckman line that was positive for this Candida dubelensis. But importantly, in looking at central line associated bloodstream infections, you need to ensure that it's not secondary to something else. And it's defined by patients that have had a central line recently, or a central line that has been removed within the past 48 hours. And to assist clinicians and ID specialists to understand what if this is a central line associated bloodstream infection versus a fungemia itself, is something we look at as the differential time to positivity of 2 hours. So what I mean by that is, if you take two blood cultures, one from the central line and one peripherally, we compare the time that they become positive. So if the microbiology lab calls you at 9 o'clock and says the central line blood culture was positive at 9 a.m. with a fungemia, and then they call you at 10:30, so within 2 hours, and they say your peripheral blood culture is also positive, that makes a central line, a CLABSI, less likely. However, if they call you at 9 o'clock in the morning and say your central line is positive, and then they call you, for example, at 12 o'clock, so more than 2 hours later, and they say that the peripheral line is also positive, then that suggests that it's potentially due to a central line related bloodstream infection. Another option is to, when removing the line, sending off the tip for culture. And in saying that, please don't send off CVP tips in patients that there's no suspicion of infection. Inevitably, what we commonly see is that they become contaminated with skin flora, and then it makes it very difficult for people to decide whether this is actually a CLABSI or not. And another important thing is to look at the lumens and growth. So what I mean by that is, if you've got a central line inside, which has got 3 ports, then you actually need to take cultures from 3 ports. as well as the peripheral, because some lumens one lumen out of the 3 may be infected while the others aren't. So that's another thing to keep in mind. And there was a very nice NEJM article which came in 2023, and I would recommend for those interested on prevention of CLABSI, so using bundles of care, this is quite a nice article to go and read. Okay, so as I said in the beginning, there's some literature coming out with regards to the duration of therapy with candidemias. And this article was done in 2022. It is a retrospective study, and it only looked at 114 patients. 35 patients were moved into the short course arm of 5 to 11 days of appropriate antifungal treatment, and in the other arm, prolonged treatment in 79 cases, and the prolonged treatment was 12 to 24 days. And of note, only 11 of these patients were hematopoietic stem cell transplants or hem-onc patients. So again, a little bit different, potentially different in the population that we are discussing. And what they have shown is that the cumulative incidence of the all-cause 90-day mortality for prolonged course and short course was not different. And then again, if you're looking at the cumulative incidence of 1 year of recurrence as well as 1 year of mortality, once again, there was very little difference between the two groups. I think we'll need further studies to look into this before we can do this as a mainstream treatment protocol. And for now, as mentioned, it's important to give these patients 14 days from the first negative blood culture before stopping therapy. Okay, and then to move to the next few patients, I thought we should discuss aspergillosis a little bit more. And there were a number of questions that I had, and what diagnostic modalities are available to us at Chirurgia? What is the difference between possible, probable, and proven aspergillosis? What are the treatments are available to us, and should therapeutic drug monitoring be done for our patients? And as we heard earlier from Bridget, that the third patient actually had Aspergillus osteomyelitis, which is very uncommon. I've only seen 2 cases in the past 4 or 5 years. So quite an interesting patient to discuss. Okay, this is quite a nice article. It's a consensus guideline by Douglas et al., which was done in 2021. It's by our colleagues in Australia. It's quite a simple guideline. So for those that want to know more about aspergillosis and its management from a hematopoietic stem cell transplant point of view as well, I would recommend looking at this article, and to look at what are the modalities that are available for us to try and assist in seeing if patients have aspergillosis, because unfortunately it's quite difficult to make this diagnosis. You can't do a blood culture on a patient and find it positive for aspergillosis. So looking at the structure of the aspergillosis, we can see over here it has glucans involved, and it's also got galactomannan in its structure, which is important for trying to define which tests are important for trying to find out what the organism, to try and help assist to see if this is aspergillus that needs to be treated. So there are a few options. You can do a blood galactomannan, and it's usually done in patients for screening for invasive aspergillosis in the absence of mold active prophylaxis. The sensitivity only sits at about 78-79%, with a specificity of 85 to 86%. Now, the issue comes in when you have a patient where they're on mold active prophylaxis, then the galactomannan has an even lower positive predictive value. And in doing the blood galactomannan for this patient population is probably not useful. And then again, doing blood galactomannans for the diagnosis of invasive aspergillosis, the sensitivity is poor. So blood galactomannan, probably not the greatest test to be doing for our patients. However, in doing a bronchoalveolar lavage galactomannan, that is quite helpful for the diagnosis of pulmonary invasive aspergillosis. The sensitivity is 61 to 92% with a specificity of 81 to 98%. Now, as we already mentioned, Bridget mentioned the second patient that had a the third patient who had a high beta D glucan of 131. And as you can see, a sensitivity of 78 to 85% with a specificity of 91 to 98%. Sorry. Okay. But now looking at this interpretation of results, and I think this is quite important to know because people think that galactomannan is aspergillosis, beta-D-glucan is candidemia, and it can't be anything else. In actual fact, there's other organisms which can cause cross-reactivity, and that's also based on the structures of these organisms. So for galactomannan, you can also find it positive in deep fungal infections such as histoplasmosis, blastomycosis, Telleromyces, as well as fusariosis. Now, what's interesting is when do we see it in false positive cases? And false positive is seen occasionally in patients that have graft versus host disease. And it's thought that potentially it's the chemotherapy and so forth, which have resulted in the mucosa being permeable and fungal elements moving through, can cause the galactomannan to be falsely positive. Even eating contaminated foods with aspergillosis, looking at beta-lactams, and that's part of the process of beta-lactams being produced, as well as being contaminated in the process of it being made. But in saying that, I think that's a very uncommon cause of a false positive galactomannan. Furthermore, IVIG and albumin both contain galactomannan, and there's even been reports of plasma-light infusions containing galactomannan causing the false positivity. If we look at beta-D-glucan, we can see that it is positive in patients with PCP and aspergillosis as well, as we mentioned. False positives for similar reasons as graft versus host disease and cellulose products. Now, what does that mean? So cellulose products are, for example, back in the day, they used to have hemodialysis filters that were made of cellulose, but that's no longer used. Furthermore, there were cellulose products in gauze material. So their patients' abdomens that are packed with gauze can cause a false positive BTD. And then again, beta-lactams and IVIG, as mentioned earlier, can also be involved. Now, this is what I was mentioning with regards to trying to define and trying to assist clinicians in deciding if a patient has got aspergillosis, invasive aspergillosis or not. And there's three categories. So one of them is possible, probable, or proven. And possible invasive aspergillosis looks at the host. We've already discussed many of these factors because the same factors that occur in candidemia are the same factors that you'll find in aspergillosis. And then clinical data that we get is, for example, patients that have CT findings, X-ray findings that are in keeping with an invasive aspergillosis. Now, probable is when you also have microbiological evidence. But in saying that, microbiological evidence is using your non-culture-based methods, such as your galactomannan, your beta-D-glucan, and also even bronchoalveolar lavage, which grows a aspergillosis. Now, proven And as we said for the last patient, this patient did have proven invasive aspergillosis, which was based on histopathological diagnosis, as well as growth of the aspergillosis on the specimen taken from the otic area. So importantly, when looking at the histopathological, which is seen as the gold standard, one also needs to make sure it's not just colonization. So when they do the histology samples, for example, in our patients that have pulmonary aspergillosis, if they see angioinvasion, then that suggests that there's invasive aspergillosis. So further testing that can be done is DNA PCR as well as culture. Unfortunately, we don't have DNA PCR. I'm not sure if the NICD does have that, National Institute of Communicable Diseases. Yeah, and then now with regards to a little bit on the treatment again, the only difference now is that in place of fluconazole, I've put voriconazole over here, and then again, I've put the prices of these drugs, and as you can see, it is very expensive once again to give treatment for these patients. That is something to keep in mind, especially if you are in resource limited areas. And then just this is also a nice article. So by Ullman et al, and it's from the Europeans, and they go into the management and of aspergillosis. And it's a good article in the sense that it gives you a lot of insight into how to treat these patients, but it is quite a long article and it gives a lot of detail, but it is still very good. Okay, and what I liked about this article is where it talks about giving empiric therapy to these patients with hematopoietic stem cell transplants, and to consider it when the patients are neutropenic for at least 96 hours, and patients that are not responding to empirical antibiotics. Some centers will say for more than 48 hours, others will say for more than 96 hours, and one can consider giving these drugs over here. So caspofungin, liposomal amphotericin B, voriconazole, amphotericin B, and micafungin. What's interesting is that we generally use the countercandins interchangeably, but if you look at the evidence surrounding caspofungin, there's more evidence for its use compared to micafungin, which is based on the strength of evidence as well as the quality of the evidence. So just for people that don't know, there's ABC for strength of evidence, and that's based on strong recommendation, moderate recommendation, marginal recommendation, and then the quality of evidence is based on whether it's randomized controlled trials, whether it's prospective trials, and furthermore, if they're just case control studies or in patients that have had or expert opinion. So as you can see, the most data is for caspofungin. In saying that, we use voriconazole the most because we have access to it, and there is relatively good evidence to support its use in this patient population. Now, other management considerations is to decrease the immunosuppressive if possible. Not always that easy in our patient population, especially when we are doing induction therapy for them, and then giving them granulocyte colony stimulating factor, and then even doing surgical resection in localized disease or refractory to treatment, or if there's complications. So already on the third patient, we already mentioned that he had an aspergillosis of the otomastoid area, and we pushed for him to get surgical debridement, not only for diagnosis, but also for source control. And importantly, to one of the other parameters is to look at TDM, so therapeutic drug monitoring, and we have this available to us. Unfortunately, it does have to be outsourced to the private labs at Groote, and this is for voriconazole. And as you can see in the graph A, treatment success is mainly seen between a voriconazole trough level of 1 to around 5.5, but neurological toxicity occurs in a trough level of more than 5.5, and the toxicities that patients get is related to neurotoxicity, and some patients will complain of hallucinations as well. And the question is, when do you do voriconazole trough levels? And that's based on time to steady state. And what we generally do when we give voriconazole is we give it IV initially for a day at 400 milligrams BD, and then the second day we change over to an oral-based regimen of 200 milligrams POBD, and the levels can be taken between 2 and 5 days after starting. If your level is subtherapeutic, then you need to increase the dose, and if it's supratherapeutic, you need to stop and then give a slightly lower dose. When do you repeat the levels again? Well, generally between 4 and 7 days after you have adjusted the dose. And then furthermore, if you have reached steady state and your level is fine, you don't need to check again. However, in patients that have a change in their clinical condition, or there's a change in drugs, then one does need to do the voriconazole levels again. And please keep in mind, there are actually quite a lot of drug interactions with regards to voriconazole and some of the chemotherapeutic agents that are given. So it is pertinent that and important that colleagues on the call do ensure that they go and make sure there is no interactions or otherwise change the levels of the drugs that people are working with. Okay. And to come to the next point of all of these patients that we're discussing, and as you can see, they're very complex, and we always have a lot of discussions, and we have rounds with our hematology colleagues every Thursday morning to try and assist these sick patients. And we have the hematologists, the infectious disease, the microbiologists involved, and then also pharmacology is also involved, because as you can imagine that a lot of these patients have very difficult cases, and a whole multidisciplinary team is necessary to put things together. And then lastly, going to our patient who has the osteomyelitis. So this was a review of aspergillosis osteomyelitis in 2014. And as you can see over here, the cranial aspergillosis was 41 patients out of 180 of these patients with osteomyelitis. And in actual fact, very few of them were hematopoietic stem cell transplants. Only 3 were that. And what they did for these patients is patients were either given, well, they were described, and they were either treated with antifungals alone, or they were treated with antifungals plus surgery. And the duration of therapy is very long, with a median of 90 days, but up to 365 days. And for this gentleman with the otomastoiditis, we've decided to put him on at least 3 to 6 months of therapy, but obviously revisiting his treatment based on how he does clinically. And what was interesting is that on these patients, complete response was actually only seen in 58% of patients, which is quite worrying. And it shows that these conditions are not very easy to treat. And when they looked at these studies, they showed that the patients that had antifungal as well as surgical debridement were the ones that were less likely to have recurrence of the disease compared to those patients who had medical treatment alone. So in summary, just some take-home messages. One needs to be aware of is the interpretation of the results. Don't order tests if you're not too sure how to interpret them. And secondly, we don't do a lot of galactomannan or beta-D glucan because it doesn't influence our management of the patients, because it takes so long to get the results back. In our setting, it takes around 1 week. And by then you've already made your decision on therapy. Furthermore, de-escalation, as I mentioned earlier, it's important that we practice good antifungal stewardship, meaning that we need to change over once the patient is better from an IV to an oral option, from a more expensive to a cheaper option. And then please also, when treating these patients, it's important that we involve a multitude of people in the discussion, seeing that these patients are quite difficult to manage. Yeah, thank you very much.
Thank you, Terry. We are now going to move on to which is going to be quite difficult to manage, a panel discussion. I've also got some questions for you and the panel. I'm going to say, Estelle, I'm going to resist my soapbox opportunity to further the fight between the Gauteng and the Western Cape in this regard. But we've got a good panel, Estelle and Cecile, hematologists, Sean, infectious disease, and Elizabeth, a microbiologist, are going to join us now. And I guess Terry as well will continue to be on. So just in terms of Candida or yeast, so the microbiology infectious disease team, antifungal sensitivity testing. Yes, no, based on
this one
guidelines, based on in-house and the difficulties in doing and interpreting that.
Elizabeth, we can't hear you.
Beg your pardon, I wasn't unmuted. For yeast, it's not so difficult. It's fairly standardized. We do it in an automated fashion. But for molds, although there are breakpoints, it's a bit more tricky, and we have to send it up to the NICD. But organizations like UCAST are developing ways to and are influencing CLSI to develop ways to do antifungal susceptibility testing, but it is slightly more difficult.
I mean, just a comment. I mean, there is increasing concern for mold and aspergillus resistance. Can you comment on that? Are you seeing it at all?
We don't routinely send our molds for susceptibility testing. So I can't really comment on that. But as far as from the literature, I haven't seen much reported in South Africa.
Okay, so I'm going to ask the clinical team, just in terms of yeasts, what's your approach to source control in terms of you've got a positive blood culture for Candida, whatever species, whether that's the ones you've got in Cape Town or our more prevalent Auris and Paracellosis and Gauteng. So
I'm going to jump in here, leave all the difficult questions to Cecile. So this one I can answer. Pluck it out wherever it is. That's the answer I have. And I see Sean wants to chat to us. So I don't know if he has a point about that.
I mean, yeah, I've got a more nuanced comment on this question. Actually, I mean, before we kind of move on, Andrew, if that's okay, from your question of antibiotics or antifungal susceptibility testing, I've actually got a question for Elizabeth, because this is a problem for us and in general, and that is around clinical breakpoints for Candida glabrata and fluconazole. I mean, we always want to de-escalate. We want to know if we can de-escalate to either VORI or fluconazole. I mean, can you comment on glabrata susceptibility testing?
Who's that going to?
That's it. That's of course the microbiologist.
Okay.
Yeah, hi Sean, they've removed the susceptibility category for Candida glabrata and fluconazole. both in UCAST and in CLSI, because there's been an increase in resistance and because it's not been shown to be such a good target anymore. So it's actually all intermediate. And we don't actually report fluconazole as susceptible anymore because it's just generally seen as not being useful.
Thanks. That's the point that I wanted to bring out. We avoid fluconazole for glabrata, and voriconazole is a little bit more difficult.
Yeah.
And then Andrew, in terms of your question around the line and invasive candidiasis, I kind of take a more nuanced approach. I mean, these patients that we're talking about now, patients with stem cell transplants, have mucositis, and that is like a major port of entry for Candida. And I think patients can, and all of them have central lines in at the same time as well, right? So they've got two major risk factors. And these central lines, as you know better than me, can be very tricky to take out and risky to take out, and could be more risky to take out than to leave in certain patients. And so, if a patient has mucositis and they culture Candida from their line, I don't necessarily immediately take it out and take a more kind of nuanced clinical approach about the risk benefits in that particular situation. And the evidence supports that. I mean, randomized controlled trials for line removal in invasive candidiasis is not in this population. And in fact, only survival benefits in a subgroup of patients with, Apache scores of 3 and the others not, compared to retaining the line. So I think we kind of on safe ground to use our clinical judgment.
What would you be doing, Andrew? Because we have very little of it, and that's why I'm saying what I'm saying, because we actually only have it when we use steroids. Honestly, Cecile can also jump in here. We don't get it when we use steroids, or when there's not a foreign body, a foreign thing like what's the word, a stent or something. So that's my opinion, but I'm happy to hear, and I agree with you, Sean, that if somebody is on a lot of steroids and there's a Candida, there's probably a lot more happening than only the line. That I agree with. So Cecile and Andrew, over to you.
Well, I'll just say that, yes, obviously, we, as Estelle was saying, we see very little. This recent one with this Candida with a difficult to pronounce name is very, very uncommon for us to see. I can't remember before that when last we did see a candidemia in our F4 unit. And my sort of feeling was always like, Estelle, just when in doubt, take the lines and everything else out.
But was that not the patient that actually had a stent in, or was that a different one, Bridget? Is it not the same patient?
Sorry, Estelle, which patient?
That not the patient who actually had a stent in? Or was that a different lady?
No, that was a different patient.
That's a different one.
Different one, yeah. Different one, yeah.
Okay, so that is very unusual. That we get this. That it's really highly unusual. We definitely have a different pattern from you guys, Andrew. Definitely.
Yeah, I mean, to say that, I mean, we obviously seeing, I mean, as Garrick alluded to, Gauteng, there's a lot of auris, and we also have quite a bit of paracillosis, which is also one that's very much associated with sort of plastics and biofilms. So we've been a lot more aggressive at taking lines out. But I mean, Sean's comment remains that it's risky changing lines in the depth of cytopenias, and all you need is a little bit of platelet refractoriness thrown into that, then and you really are struggling to change lines and control potential sources of infections. Just a question on bone penetration of the agents that are being used, and since you did present a case that had bone involvement, that we've talked about duration of therapy. I mean, we agree. We've also had a couple of osteitis, osteomyelitis, but varying agents with bone penetration. Terry, you mentioned CSF, but in the setting of the third patient.
Yeah, thanks. I'm sure Sean knows more than I do about this, but bone penetration for voriconazole is good. We've actually got another patient currently that has a discitis with the Candida krusei, and we're giving him 6 months of voriconazole therapy. Yeah, good penetration as far as I know. I don't know the more specifics about it though.
And just one last comment before we leave Canada. I think the microbiologists and the dermatologists vie of changing the names of their organisms or diseases. I'm not sure who wins that battle, but yeah, sure, the names of some of these new ones are. I posted it on one of our groups on the weekend, and people were horrified. I mean, but anyway, moving on to Aspergillus. So ERTC grading of in terms of possible, probable, and proven. So I'd actually like to ask the team what your approach would be. How likely would you be to treat a possible? Because obviously going to be a lot more possibles than provens, and it's particularly given your difficulties in terms of accessing galactomannan. It's not always possible to do a BAL. Doing sputum is very difficult because often there's contamination, PCR by Aspergillus and galactomannans all over the place. So what's the team's approach in terms of you've got a patient with fever and a radiological sign that is highly suggestive of a
possible, is that not a probable? Because I think possible, doesn't even exist. It's
probable you've got some sort of a biomarker or something. Possible would be that you've got a patient and you've got a CT that's let's say suggestive there's a lesion with a halo sign.
For me, that's very probable. Personally, I would think that's, all I know is that we don't that often do the scans, and if the scan would show that, we would definitely see it as I suppose, probable. I don't want to get into all these terms of probable, preemptive, because I think it's really something that in Europe I thought of all the time, while here we really rely on our ID team to help us to think what to do next. I think we really very much, it's a very, I think that the help and the stewardship we get from them is sort of what we rely on. So we would definitely, somebody with a halo sign, we would definitely treat wherever I've worked. That's a definite. The definite diagnosis, speaking of definite, the definite diagnosis of Aspergillus, I don't think I've worked anywhere. And now I'm not going to go into these deep, grading or whatever, but really getting an Aspergillus from a bell or whatever, once in a lifetime. And galactomannan was used very extensively where I used to work in Belgium, because the guy there was like the world authority on galactomannan. And I don't know if that meant we treated a lot of people rightly or wrongly, because we were treating them all the time. So I think I see Sean has a different.
Yeah, so Carrie first and then Sean.
Okay.
Thanks. So I find it quite helpful to look at the possible, probable. So in most cases, what we end up doing is we sit in the possible category, okay? And as we said, that depends on the hosts and then the clinical findings. So we're quite lucky in the sense that if we get a patient that's not responding to broad spectrum antibiotics, they're starting to look more sick, then we'll send them for a CT scan. And generally our CT scans, if they are urgent, will be done that day. And based on that CT scan, then we go down the route of saying, okay, right, we've got a CT scan, which is in keeping with invasive aspergillosis. We see that there's angioinvasion based on that imaging. And then afterwards, we'll say, right, let's give the patient voriconazole and start treatment. The thing is, because these patients are generally so sick, you don't have a lot of time to do a lot of the investigations. It would be really useful if we can also do bronchoalveolar lavages on the same day on these patients, but that's not always possible. But we were quite lucky in the last patient who had the otomastoiditis that he went for a bone biopsy. So he was a proven invasive aspergillosis. Thanks.
Sean?
Yeah, I don't actually think about these categories at all in clinical practice. They actually aren't meant for clinical diagnosis, decision making. They're research tools to categorize patients so that we can assign So we can assign effects to different groups of patients at different levels of certainty. That's for a clinical trial. I have a very straightforward, simple approach, and that is persistent fever in a patient with risk factors for invasive mold infection gets a CT chest, because that's the easiest test to do. And if there's a suggestion, then they start therapy. It's like the threshold in that context, someone at risk, chronic GVHD, steroids, prolonged neutropenia, certain chemotherapeutic agents. The threshold should be quite low because it's like a rapidly fatal condition. And I think we should, get as much supportive evidence as possible and start treatment. The difficulty is that not all changes on CT and not all causes of prolonged fever are due to invasive aspergillosis. There's the odd case of mucor infection, and obviously voriconazole, which is the first-line treatment for invasive aspergillosis, is not mucor active. And so in some cases where there's a lot of uncertainty, but we think that there's a mold, then using amphotericin instead of voriconazole initially, and then building supportive evidence for aspergillosis if possible. Galactomannan I don't find helpful because of the long turnaround time and the poor performance characteristics on blood. The ultimate sample to do it on is bell fluid, as Tari kind of showed. But again, that's difficult to get. If you can get it, it's very useful, especially if you start a patient on empiric voriconazole and then like 5 days later they develop hepatitis and you really don't know what to do. And so, it's good to even retrospectively build a case. So that's my approach.
Okay, so just a question. I mean, there was a question about duration of therapy for aspergillus. I mean, we're doing 3-month standard vori. Some people I see are doing 6 weeks. Is there any consensus on that? And then the follow-up question to that, what are you doing if you see a refractory aspergillus on voriconazole? Cecile, Estelle, maybe I'm gonna throw you in the deep end here.
Okay. Well, fortunately, we have not seen an obviously resistant aspergillus, so we haven't come across that yet. As far as duration of treatment, we are largely guided by infectious diseases, and it also obviously will be determined by the patient's immune status. Is there still steroids around? Is there other immunosuppression? And what we have now, what we're facing with our guy with a mastoiditis, is that he is aplastic anemia and he's going to stay on his calcineurin inhibitor for at least a year. So there's issues around that. But obviously, if he's cleared it completely and is well, we may be able to come off, but he's not going to be having completely normal immune system for a while. Yeah, but we discuss each individual case with our ID team and make a plan together.
Yeah, I think that is very important. So, Jacques, I didn't want to mislead you, but it's basically if somebody has been properly treated and out of risk, that's when you will continue for a limited period and perhaps again give it. We don't see it often. I have a question for Andrew. I would love to know how often you can actually find it in bowel. Do you use it? Do you rather treat? I'm not going to use these terms that Sean doesn't like, preemptively, whatever. How do you typically go about? Because wherever I've worked, it's, as we've all said, it's not very easy. You don't have much time. You must make a decision. And we have little of it in Cape Town, very, very, very little compared to, I'm sure.
I think there's a significant difference in aspergillus incidence between Gauteng and Cape Town. I mean, Jackie and I always just have this discussion and debate, but I do think there's actually less in Cape Town. So
definitely.
That actually really informed our decision. I know that we haven't really brought up the prophylaxis in terms of transplant, but we're actually giving posaconazole prophylaxis to all of our allogeneic stem cell transplants routinely, which obviously then means we're not doing regular galactomannans and makes it very difficult to interpret. And as Terry indicated, the positive predictive value of the test is going to be very low. Well, actually, just trying to pick it up is difficult on biomarkers. So actually, we don't really see. Most of the aspergillus now we're actually seeing is probably not in our transplant population, but in our varying hematological population, even patients who are not sort of typically high risk with lymphoid malignancies. So and then we actually now have access. I mean, prior to this, we only had the suspension of posaconazole, which was really, patients hated it. The absorption characteristics are dreadful of that drug. So we now do actually have access to the tablet, so that the typically get 300 milligram daily prophylactic dose of posaconazole. The big issue is we don't have therapeutic dose monitoring. So so we were very, very different approach in Gauteng and in private. I just wanted to ask about therapeutic drug monitoring, because obviously, especially this is normally a transplant talk, and then fungal infections, especially allogeneic, who are at risk, are often on calcineurin inhibitors. We're now started to, in certain patients, give letermovir, the CMV prophylaxis, which also has a significant number of drug interactions as well. So in terms of therapeutic drug monitoring, and we did mention it, but just comment on how important and what you think its place is. Anyone from the team can answer.
Maybe I'll go first. I mean, in terms of the antifungal agents, I mean, you can speak about the calcineurin inhibitors. Obviously, you monitor INR as well, someone's on warfarin. But in terms of the antifungal agents, voriconazole is the drug to monitor. It's got all the characteristics that support use of therapeutic drug monitoring. It's got wide inter-individual PK variability. It's got a narrow therapeutic index. The concentration that causes toxicity is very close to the concentration that's required for efficacy. And there's actually targets that have been established, and so it really lends itself well to TDM. And in fact, there's pretty good evidence for clinical evidence for use of TDM, voriconazole TDM. There's been a randomized controlled trial that shows better clinical outcomes, less treatment discontinuations because of toxicity in people that get TDM on voriconazole. And so if it's available, I would strongly support it. I think it's just, and also just supports good clinical practice. The other drugs, Andrew, I don't think posaconazole requires TDM. The PK is much less.
You don't have it available anyway.
Yeah, and it's not available. So voriconazole would be the drug that I'd monitor. And then obviously, all azoles, all of them, inhibit cytochrome P450 and other isoenzymes, and calcineurin inhibitors are the main issue. One other thing to mention, and I mean, you'll know more about me than this, venetoclax is extensively metabolized by CYP3A4. And if you give that together with an azole, that's a huge problem. It could cause toxicity. And that's the one time that people are using isobuconazole. And I don't know if you have access to that azole.
So we don't. We're actually leveraging azoles to reduce the dose of venetoclax. I think in line with probably most people in South Africa who have access to venetoclax, we're using a quarter of the dose of venetoclax combined with one of the sort of early either fluconazole or ketoconazole. The issue of posaconazole prophylaxis in these patients is also a whole nother topic. Tari?
Yeah, thanks, Andrew. I just wanted to mention the answer to one of your questions that you were talking about, what to do if there's suspected azole resistance for these aspergillus cases. And it's also based on the MIC to the voriconazole. So if your MIC2 voriconazole is sitting at 2, you could get away with combination therapy of voriconazole plus an echinocandin. But if your MIC is more than 2, then you should consider changing over to liposomal amphotericin B. And some people have even gone with voriconazole plus an echinocandin combination, even though the resistance is up there. Yeah, thanks.
So I think we're getting towards the end. We're probably going to have to close pretty soon. But Jock did have one question about hepatosplenic candidiasis and incidence. Are people seeing that as a clinical entity, not only specifically in a hematopoietic stem cell transplant, but across hematological malignancy spectrum?
I must say, from our side, we haven't seen for a while. I've certainly seen in my career, but not recently.
It's in the textbooks, but I don't actually think it exists.
I disagree, but yes, I agree with Cecile. I mean, I think we may have a case at the moment, but it's probably comes around every couple of years, 3 or 4 years actually. So I'm not seeing an awful lot.
Especially in the context of high TB prevalence. Yeah, it's difficult.
Well, you may be just misdiagnosing it and calling it TB, but anyway, that's that's a very different discussion. Okay, I think we.
Oh, you're now muted, Andrew.
Am I muted? Sorry. Yeah, I have a lot of background noise at the moment. So I think we need to pull this to a close. So thank you everyone for our panelists and our speakers and for all those who attended. And yes, it's been a very interesting session, and I think we've all learned quite a lot. So thank you very much for taking part, and we'll see you all again next week.
We so appreciate you chairing, Andrew, and thanks Sean, and thanks Tari and Elizabeth and everybody. I didn't think I would enjoy it so much. We must talk about it again. So thanks.
Thank you.
Thanks everyone.
Thank you.